Hello everyone! Welcome to my SOAP presentation. My name is Lovella de los Santos. We will be focusing on the case of a 67-year-old Hispanic male born on January 1, 1957 with the initials of SCT. He is married and he came to the clinic alone and he is a reliable historian. His chief complaint is, for the past week now, I have had chest pain. For his history of present illness, SCT is a 67-year-old Hispanic male presenting to the clinic with complaints of chest pains. The pain began 1 week ago and is centrally located in the chest. Each episode of pain usually lasts a few minutes, with the longest episode lasting 5 minutes. The pain is described as pressure-like in character and is aggravated by exercise and alleviated by rest. Whenever the pain occurs, it radiates to the left shoulder. It is intermittent, coinciding with the activity of the day. The patient notes that the pain is sometimes severe, often interfering with his activities of daily living, and he rates the pain as 7 out of 10. Additionally, the pain is sometimes associated with episodes of nausea and shortness of breath. For his past medical history, he has a medical history of hypertension for 10 years and diabetes mellitus for 5 years, with no history of surgeries. He had a dental exam in February and a prostate exam late last year and regularly attends diabetes and hypertension clinics. He has no known allergies and is on metformin 500 mg twice daily for his diabetes and nifedipine 30 mg daily for his hypertension. He is up to date with all vaccines, including a recent COVID-19 booster and annual flu shot. Socially, he is a retired salesperson, business owner, and a social smoker, and abstained from alcohol since his diabetes diagnosis. He is married, sexually active without contraceptives, and follows a diabetic diet. He lives with his wife and 3 sons in a safe 5-bedroom mansion, owns 2 guns kept security, and practices safety behaviors. His family history includes significant cardiovascular illnesses. His father died of a myocardial infarction at 60. His mother has heart disease, and his brother has diabetes and hypertension. For the review of system, SCT denies weakness, recent weight changes, fever, or chills, but reports fatigue or non-strenuous activities. He denies visual changes, double vision, or the use of visual aids. He has no tinnitus, ear discharge, hearing loss, nasal discharge, or congestion. He has no gum issues, sore throat, or difficulty swallowing. For cardiovascular, he denies palpitations, irregular heart rhythms, or extremity swelling. He reports intermittent chest pain for 1 week, aggravated by exercise and alleviated by rest, but denies cough, wheezing, or shortness of breath. He has no gastrointestinal disturbances, or abdominal pain, or changes in bowel movements. Genitourinary symptoms such as dysuria, urinary hesitance, or frequency are absent. He denies musculoskeletal pain, swelling, stiffness, or joint issues. His skin shows no scars, lesions, or color inconsistencies. Neurologically, he denies dizziness, headaches, or syncope. He has no psychiatric history or family history of mental illness. As a non-diabetic, he is responsive to medications and denies heat or cold intolerance. He has no hematologic or lymphatic issues such as easy bruising, excessive bleeding, or lymph node swelling. He has no known allergies. And for his physical examination findings, on examination, Mr. SCT is well-kept, well-nourished, and not in any respiratory distress. His vital signs are as follows. The blood pressure is 150/90, the pulse rate is 85 beats per minute, respiratory rate is 16 beats per minute, and temperature is 98.6 degrees Fahrenheit. The cardiovascular system assessment shows no abnormalities. S1 and S2 heart sounds were heard. There were no murmurs, rubs, or gallops. There is no wheezing, crackles, or rhonchi. His lungs are clear to auscultation bilaterally. There were no visible distended neck veins. His jugular venous pressure, or JVP, was normal. His peripheral pulses were present of good volume and character, and bilaterally asymmetrical in both the upper and lower limbs, which suggested adequate peripheral perfusion. There is no jaundice, cyanosis, or peripheral edema. For the assessment, I have come up with 4 differential diagnoses. The first one is the stable angina pectoris. Angina pectoris is characterized by chest pain due to myocardial ischemia, often felt as pressure in the chest, neck, or left shoulder blade, typically triggered by physical activity or stress. Given Mr. SCT's history of hypertension and diabetes, his exertional chest pain relieved by rest strongly suggests angina pectoris, and that is according to Joshi and Lemos, writing in 2021. Another differential diagnosis is gastroesophageal reflux, or GERD. Involves stomach acid backflow into the esophagus, causing irritation and chest pain similar to angina. While Mr. SCT's chest pain could be due to reflux, the exertional nature of his pain makes GERD less likely. according to Tomaro and Lopez-Sendon, writing in 2022. For the musculoskeletal pain from strain or inflammation of chest wall muscles can mimic cardiac pain. So although Mr. SCT has no recent physical strain, this diagnosis is considered to rule out all possibilities sources of chest discomfort, according to Tomargo and Lopez-Sendon, writing in 2022. And the last differential diagnosis is the costochondritis. It is an inflammation of the rib cartilage, causes localized chest pain that worsens with deep breaths or physical activity. While less likely, it remains a possible cause for Mr. SCT's exertional chest pain, according to Tamargo and Lopez-Sendon, writing in 2022. Now, what is my final diagnosis? My final diagnosis is stable angina pectoris. SCT has a stable angina pectoris, and this decision is based on his presentation of pressure-like chest pain radiating to his left shoulder, triggered by physical exertion and relieved by rest. His history of hypertension and diabetes, both significant risk factors for coronary artery disease, supports this diagnosis. Additionally, the pain's pattern and characteristics align with classic angina symptoms. The absence of acute symptoms such as diaphoresis or severe shortness of breath further suggests stable rather than unstable angina. That's according to Joshi and the Lemos, writing in 2021. Now, what is my plan of care? So angina pectoris is characterized by chest discomfort triggered by exertion and alleviated by rest. And that's according to Mago and Lopez-Sendon, writing in 2022. The diagnostics will include an ECG to assess myocardial ischemia or past infarction, as recommended by the AHA or American Heart Association for hypertensive patients with chest pain. A chest x-ray will be performed to rule out non-cardiac causes of chest pain such as pneumothorax, infections, and trauma. A complete blood count or CBC will help identify any inflammatory processes like anemia and infections that could cause chest pain. Treatment will focus on lifestyle modifications, including tobacco cessation, regular exercise, and a diet low in saturated fats, sodium, and cholesterol to manage angina and reduce cardiovascular risk. Medications such as nitroglycerin, beta blockers, and aspirin will be considered for a symptomatic patient, and it will start on low-dose aspirin and nitroglycerin at 2.5 mg every 8 hours to reduce attack frequency. Education will involve informing the patient that angina pectoris is a symptom of myocardial ischemia that can progress to acute coronary syndrome if unmanaged. Emphasis will be placed on the importance of lifestyle changes and preventive pharmacotherapy to control symptoms and preventive attacks. The patient will be advised to adhere to anti-diabetic and anti-hypertensive medication to optimize blood pressure and glucose control, reducing the risk of coronary heart disease. A follow-up visit will be scheduled in 1 month to reassess the efficacy of the treatment. That's all for today. Thank you so much for listening.